Good morning, everyone. Thank you for joining us. Give it a couple moments for our attendees to log on and get settled. This is the Disability and Aging Community Living Advisory Committee, or DACLAC, D-A-C-L-A-C. You will be hearing that a lot, DACLAC, Disability and Aging Community Living Advisory Committee. Today is October 9th, 2025, and this is the third and final meeting of this committee for 2025. So we appreciate your being here with us in the virtual space. I'm going to go over a few logistics, and my name is my name is Carol DeAndres, and I am the Stakeholder Engagement Manager for the Master Plan for Aging, or MPA, here at the California Department of Aging, or CDA. Lots of alphabet soup going on. We have accessibility functions available to you. As you can see, we have American Sign Language, so we appreciate Rex and his partner Heather for helping us out today. We have closed captioning available to you. So if you look on your Zoom toolbar, there should be a CC icon. And if you click on that, you will be able to view the full transcript. If you don't see that CC icon, check under your More button, which is those three dots. Sometimes it is hiding under there. Next slide. Meeting slides and recording will be posted on the CalHHS, or California Health and Human Services Agency, MPA DACLAC page, CalHHS MPA DACLAC meeting page. Give us a couple of weeks to get that all squared away for posting. And committee members and guests, if you have yet to do so, please change your name display to your name. Right now it says DACLAC member or guest. And we would like to know who has joined us today on the committee side. So if you could please change your name display. And if you have difficulty doing that, hit your raised hand and we're happy to help you out there. Next slide. The chat function and is enabled for committee members and our guests to share out meeting related information. And our attendees can view that information in the chat during the meeting. The chat function and the question and answer functions are not available, enabled for the attendees. However, we do have a public comment period. We may have two public comment periods. We have a public comment period, at least one, and we ask that you save your comments for that time and express them orally to us. We will unmute your line. And of course, at any time after this meeting, during this meeting, please send your written comments. We would appreciate those to our Engage email box at engage, E-N-G-A-G-E, @aging.ca.gov. Next slide. For our public comment period, here are a few logistics. I'm going to go ahead and mute our folks. If you happen to be unmuted, I have just muted you. Thank you. Our public comment period, at that time, if you'd like to give an oral comment, please press *9. Rosie, can you check the panelists and help mute those? Thank you. Public comment, *9, that will indicate to us if you're attending by phone. If you're attending by the Zoom webinar, you have a raised hand icon. So go ahead and click that and we will unmute your line. Please note that we have 2 minutes per public comment, just so we have enough time to get to everyone's comment. And again, written comments are always appreciated at engage, E-N-G-A-G-E, @aging.ca.gov. Next slide. The purpose of the Disability and Aging Community Living Advisory Committee, or DACLAC, D-A-C-L-A-C, is to advance community living inclusion, and integration across California. DACLAC will ensure the involvement of individuals with physical and intellectual disabilities, older adults, and other partners who provide services or represent consumers. DACLAC will advise the California Health and Human Services Agency, or CalHHS, in addition to other state entities, on community living policies and programs, including but not limited to long-term services and supports, transportation and housing, and employment opportunities. And of course, we couldn't fulfill the committee's purpose without our esteemed committee members. And as you can see, our committee members are made up of advocates and consumers, philanthropic organizations. Let's go to the next slide. We have so many folks to be appreciative and thankful to for showing up today and doing their part, giving their time and their expertise to advance community living and advancing the master plan for aging. So thank you very much. And now we will turn it over. Let me go over the agenda before, and then Susan can get on and give her opening remarks. I went over our logistics. We have opening remarks from our director, Susan DeMorris, and we will get a Aging and Disability Lived Experience Advisory Board update, which is the Master Plan for Aging Initiative 49. And we'll have opening remarks from our esteemed co-chairs. And following that, we will have our subcommittee discussion. We do have a public comment around 11:10. Then we will have a break, continued subcommittee presentations, and then another public comment and closing remarks. So good morning, Susan. Thanks for joining us, and I will turn it over to you.
Thank you very much, Carol, as always, for starting us off in an organized fashion to begin another productive meeting of the DACLAC. I'm so happy to be here with all of you this morning, and I'm representing our two state co-chairs. Kim Rutledge, the director of the California Department of Rehabilitation, is not able to be with us today, so I'm welcoming you all on behalf of Kim and myself. I want to just start out right off the top for thanking Hagar and Sherry, our two very hard-working stakeholder co-chairs who do so much work between meetings. And then I also wanted to just let the group know we have several of our highly valued members will be cycling off at the end of this year, and we'll be inviting new members to join us in 2025. So we're currently doing an assessment of our membership, and we'll be doing some targeted recruitment to bring on additional voices and perspectives and organizations in 2025. So if you have anyone in mind that you think should serve on DACLAC, please let us know. Share those names with us. We'd be so happy to talk with them and encourage them to apply. I also wanted to give us a shout out to two of our subcommittee chairs. I am incredibly grateful to Warren Cushman and Lauren Carden. Warren has been serving as the subcommittee chair of our transportation subcommittee, and Lauren has been serving as the chair of the housing subcommittee. They've done tremendous work between meetings, organizing DACLAC and other members to inform the very important topics of transportation and housing. Currently, Warren and Lauren do not serve as official members of DACLAC, but they will be added at the first of the year when we bring on the new, I said 2025 earlier, I meant 2026. In January 2026, they will be brought on along with other new members. So I especially wanted to thank Warren and Lauren. Hey, it rhymes. I didn't realize that till I said it out loud. So thank you for all that you're doing as chairs of the subcommittees. And with that, we're going to just move to a few slides. Usually we bring you updates at a high level. I also, while the slides are coming up, I want to give special thanks and appreciation to all of our many state partners who are joining today. We have leadership from many departments on with us, and I just really thank you and your staff teams for your continued leadership and commitment and contributions to DACLAC. So I'm going to talk briefly about an initiative that the Department of Aging has been leading for the past several years. It started out as a project named California 2030. And the purpose of the project was, what can we do as a state and as a network to prepare our 33 area agencies on aging for the year 2030, when 1 in 4 Californians will be 60 or older. What started as an initiative then moved into the legislative process with Senate Bill 1249, authored by Senator Roth and signed into law by the governor. So you may hear these two terms interchangeably, California 2030 and SB 1249 combined. I'll be sharing with you where we stand with those two efforts. So the first is we formed a steering committee that was made up of leaders representing the California Association for Area Agencies on Aging. That group is known as C4A, the California Commission on Aging, the California State Association of Counties, the County Welfare Directors Association, and the California Foundation for Independent Living Centers, CFILC. So this steering committee met 10 times over the course of about 2 years. We conducted 80 stakeholder interviews during that time. Many of you on DACLAC were interviewed as part of this project. We also held in-person or virtual interviews with all 33 of our AAAs. We started this work just coming out of the COVID pandemic, and it was one of the first times we got to be in person with our AAAs and their teams locally. We also conducted a statewide survey, the first ever in California, the Consumer Assessment Survey of Older Adults, CASOA, that had a phenomenal response of nearly 18,000 older Californians from all 58 counties. We held 4 public webinars. Many of you joined. I see familiar faces. And the Commission on Aging did introduce Senate Bill 1249 that, as I mentioned, was signed into law by the governor. Once the bill was signed, we held a half-day workshop with the Department of Aging and the C4A membership to chart our course for implementing Senate Bill 1249. And we then held 9 webinars with all 33 of our AAAs. So these were topical, in-depth webinars where we would lay out recommendations, get feedback, and then report out on any proposed changes. As part of that webinar series, we also conducted 4 surveys of all 33 AAAs. So this extensive work happened over 3 years. Just wrapped up in August, this stakeholder engagement phase, and everything I just mentioned on this slide is available on our CDA website on the California 2030 page. So you can see slide decks, reports, surveys, all of it is available to all of you. Next slide, please. So the culmination of this 3 years of engagement, we're really focused on three specific areas from the outset. We're really looking at how can we strengthen the network for the headwinds coming our way with the increased population, with a more diverse population, more medically complex population, lower income population. And we're focused on 3 areas. The first is in our program area. So these would be the programs that are funded by the Older Americans Act. Some of these are supplemented by State General Fund. And we've identified 3 core programs. All of these are mandated now. All of these are funded now. And we're adopting consistent data reporting standards and timelines for our congregate and home delivered meals, family caregiver supports, and information and assistance. We're going to be working behind the scenes internally with our AAA partners this year. And next year, starting in July of 2026, we expect to have public-facing data dashboards. So consumers, families, contractors, vendors, elected officials will have access to the same information and can have comparative data to examine how funds are being used and how the population is being served. For all of these programs, the mandate is to serve people with the greatest economic and social need. That's a cornerstone of the federal Older Americans Act. So we believe this data will help us measure, are we reaching people with the greatest social and economic need in each of our communities? The second piece is we are updating the intrastate funding formula. This is referred to as the IF. It has not been updated since 1995. And all of us on this call know things have changed at the community level over the last 30 years. So we really want to make sure that the formula today and on a go-forward basis accounts equally for age, disability, income, geographic isolation in rural communities, and of course, equity. So we've proposed a formula that assigns a 20% value to each of those 5 factors so that they're equally weighted. And we did just receive approval by the Federal Administration for Community Living of California's State Plan on Aging. We submitted it in July. We received approval October 1st. This will guide our AAAs for the next 4 years. And we received a very, very high marks as a state, but there was one area where we were deficient, and that was the fact that our funding formula has not been updated for 30 years. So we were asked to promptly update that. And then the third piece of our recommendations relates to how do we designate a planning service area? That's the footprint or the map or the geography that defines an area in which an area agency on aging operates. So we are looking at the designation and de-designation criteria for both the planning and service area and the area agency on aging. So we will, through the regulatory and legislative process, we will now establish a transparent process that allows for public and community input to comply with the federal final rule. One piece of this is the right of first refusal for local government jurisdictions. This is in the federal law. And we want to make sure that everyone in all 58 counties and communities and regions across our state understand what the process is and what their part and role is in it. Next slide. So this is the final one. You saw that we have 3 areas of focus: our program performance, funding formula, and designations and de-designations. So each of those has its own timeline. We're embarking now on a new phase of work, which is our implementation strategy. And you'll see here we have lots of deliverables over the next several years. And our objective is to have all of these pieces in place by July 1st of 2020, October 1st of 2029, when our next 4-year state plan is published. And we will then achieve our goal of strengthening the network prior to 2030, which was the original title of this work, and put all of the pieces in place for statewide services, designations, and funding formula. So you'll see more about all of the things you see here on this screen about how we're going to be implementing through public input, through the regulatory process, and through the legislative process over the next 4 years. So at this point, everything is a recommendation, and the implementation phase started as of August of this year. So I'll end there. Wanted everybody to have insight into this process, please do visit our California 2030 website. And if you have any questions about this, the process, the outcome, the recommendations, please just reach out to CDA and we'd be happy to answer your questions. We do have an inbox for questions, and we continue to update our frequently asked questions. So feel free to let us know. And now I'm happy to turn it over to Sarah Steenhausen, who will lead us for the next segment.
Great. Thank you so much, Susan. I'm really excited to talk to all of you about our Aging and Disability Lived Experience Advisory Board and to introduce you to all of the members. The background and purpose of this committee is to really engage people with lived experience, including older adults, people with disabilities, family caregivers, so that we can use their voices to inform the implementation of the Master Plan for Aging. We have been so pleased to partner with our Equity Advisory Committee on Aging and Disability, who has helped us in the process in standing up this committee, providing input into the selection of the members, providing input into how we structure the meetings and how we focus the conversations. And the Equity Advisory Committee will in turn be kind of the liaison between our Aging and Disability Lived Experience Advisory Board and the other MPA advisory committees, such as DACLAC. We selected all the members ranging from 12 people from a variety of areas across the state. We sought to get as much diversity as possible and geographic diversity, as well as representation from older adults, people with disabilities, and family caregivers. We developed a very intensive recruitment and scoring process in partnership with our Equity Advisory Committee. And we just had our first meeting on September 29th, and we'll be having our second meeting later this year. Next slide, please. So we're really proud that we have members representing the northern region of the state, the Bay Area, the northern central region, our inland desert region, the central region of California, and the South Coast. Next slide, please. So now I'm really excited to introduce you to our members. First, we have Cindy Soto, who is an older adult who's had a lifelong physical disability and is an advocate in this area. Mina N is an older adult who resides in San Francisco and is very interested in addressing how people can better navigate the system and address the needs of those living with complex health challenges. Teresa is an elder tribal member who also serves as a caregiver for her family members and those in her community. Sari T is from Sacramento, and he's both an older adult and a caregiver conservator to his disabled son for the past 30 years. So he has a lot of experience navigating a range of issues in our system. Next slide, please. Dr. William D is an older adult with a lifelong disability and also a caregiver for his wife, Carol, for the past several years. But Jean Ma lives in San Francisco in a Section 202 housing residence, and she is a caregiver to her disabled niece, has been doing this for the past 10 years. Lilith is an disabled older adult who also comes to us with a lot of lived experience navigating both the aging system as well as services for people with disabilities. Kevin is a younger adult who was born is blind and who also is neurodiverse and comes to us with a lot of lived experience as an adult with a disability. Next slide, please. Debbie is an older adult who also has been a caregiver to her mother, who recently passed away from dementia, and she also has a sister that she's caring for who unfortunately also is afflicted with dementia. So she has a lot of experience navigating the world and how it impacts people living with dementia. Carolyn is an older adult who has also been the primary caregiver for her partner who has multiple morbidities. Carlos was once a resident of Ranchos Los Amigos, a large skilled nursing facility in Southern California. And since then has now been an advocate for the residents of those places. And finally, Jennifer is a younger adult who's lived with since the age of 6, has lived with juvenile rheumatoid arthritis and now serves as a caregiver for her aging parents. So we're really pleased that we have such a variety of representation of perspectives. We have people who come to us from the rural areas of the state. We have people who living in urban areas and those in more suburban regions. So our first meeting really focused on getting to know the members and understanding, hearing their stories. And we're really excited to be planning now for our second meeting. And we will be engaging the leads from each of our 6 MPA advisory committees to get input with our ECAD committee on how to structure the next few meetings. So we look forward to that. And I'm happy to take any questions that we have if we have time for it. Do we have any questions? Comments, questions? No, I don't see any right now. So Debbie said she's very excited. Thank you, Debbie, as are we. And we really, really think it's going to provide some wonderful opportunities to hear real stories and experiences of our older adults, people with disabilities, and caregivers. So thank you. I think I'm happy to then now pass it back to, who am I passing it back to now? Oh, perfect. Our wonderful co-chairs, Sherry Burns and Hagar Dickman. Thank you, Sherry and Hagar.
Thank you, Sarah. And good morning, everyone. This is Sherry Burns. It's not likely a surprise to anyone that we're living in unprecedented and stressful times. Civil rights are being violated, due process ignored, people disappeared, health coverage for low-income families and persons with disabilities decimated, and rampant violence being committed in our streets, homes, and in our community spaces, sometimes even by those wearing a badge. It's no wonder we are a bit, or even a lot, on edge. It's no wonder many of us have a difficult time concentrating at work or sleeping at night. With all this disheartening news, it is important to remember that there are good and hopeful things also happening at the state and local levels. For example, our state is still committed to the 5 bold goals of the Master Plan on Aging: housing for all ages and stages, health reimagined, inclusion and equity, not isolation, caregiving that works, and affordable aging. We are still committed to the 81 MPA initiatives developed by stakeholders for the next 2 years. We've also made good progress on achieving several key goals last year, including but not limited to making progress to reduce chronic homelessness by investing millions in numerous deeply affordable housing projects and in the Home Safe program, an APS program that keeps thousands of older and dependent adults safely living in their homes. Expanding Medi-Cal health insurance coverage through CalAIM partnerships with our managed care plans and local providers. Advancing emergency preparedness to develop an emergency preparedness guide, specifically for the older adult and disabled populations. Training 89,000 caregivers through the CalGROWS and IHSS Career Pathways programs. Connecting isolated older adults and persons with disabilities to friendly volunteers through the California Friendship Line, which is now available in 7 languages. Further reducing isolation and assisting with telehealth connections by providing nearly 90,000 digital devices and training to California's older and disabled adult populations. Continuing to move people out of nursing homes into the community-based setting of their choice through the California Community Transition Program and CalAIM Community Supports Transition Services. Also improving transportation mobility for older adults and people with disabilities through nearly $52 million in targeted Department of Transportation grants to 100 regional and local transportation providers and nonprofit agencies. You all helped achieve this. As DACLAC stakeholders and community advocates working in partnership with CDA, CDSS, DOR, DOT, DHCS, and other state departments and local services and advocacy organizations, we together advance these master plan goals and initiatives. I want you to know that among all the uncertainty and roadblocks, we are achieving great strides in improving the lives of our state seniors and those living with disability. Let's give ourselves a hand and celebrate our meaningful accomplishments over the past year and recommit to working hard over the next few years to making more of our MPA goals and initiatives a reality. We can do this together. Now I'd like to turn the mic over to my co-chair, Hagar Dickman.
Thank you, Sherry. Welcome to the last DACLAC meeting of 2025. This has been a roller coaster of a year that kept all of us aging and disability advocates busy, stressed out, and not a little bit anxious. And 2026 promises to be no different. So I want to take a few minutes to recap, similarly to Sherry, where we've been and where we're going. This year, we've faced catastrophic fires that have disproportionate impact on our disabled and older populations, leaving many people without their homes, and calling attention to the gaps in our emergency preparedness that leave people with disabilities particularly at risk of being forgotten and getting hurt. We as a community stepped up and asked for more support, more preparation, and more intentionality and thoughtfulness around emergency preparedness that puts people with disabilities and older adults at the center of planning, not as an afterthought. But these efforts have stalled to a degree and given way to other pressing priorities. So I call on all our disability and aging advocates in 2026 to continue pushing to ensure that the next natural disaster or emergency doesn't leave anyone behind. We've been facing constant federal threats to the services that keep our low-income older adults and people with disabilities healthy, fed, and housed. We've come together to educate our elected federal officials and our community members on the harms that Californians will face with the passage of the Federal Reconciliation Bill. And now that H.R. 1 is passed, we must all turn our attention to our California administration and advocate for implementation of policies that minimize harm, protect older adults and people with disabilities from loss of services, and protect access to quality, comprehensive home and community-based services, because we know that they are fundamental for community living. And finally, let's not forget the difficult budget year that promises to be only harder next year. We have shown up to legislative hearings, wrote letters, and shared stories to oppose cuts to programs like IHSS, to fight the return of an unaffordable Medi-Cal asset limit, and to ensure undocumented Californians continue to access healthcare. We haven't won all these fights, but we have had impact. The asset limit is returning, but at $130,000 instead of $2,000 as originally proposed. HSS is seeing no cuts this year, but California put a freeze on new enrollment of undocumented adults in Medi-Cal, reminding us that 2025 has been a step back from the progress that California committed to in the Master Plan for Aging to provide healthcare for all, and that 2026 must remain a year of vigilance, advocacy, and unity among aging and disability advocates to continue pushing for policies that mitigate harm, press forward with equity and access, and prioritize the needs of all older adults and people with disabilities so we can have a fully inclusive California where community living is accessible for all.
Thank you, Hagar. Yeah, we definitely have accomplished a lot, and we have much more to do working together over the next couple of years. So thank you for that. We are going to spend most of the rest of our meeting with the presentations and discussions from our subcommittee chairs and our subcommittee members. We will be starting with the Housing Subcommittee, then moving into public comment after that. And then we will do Community Home and Base Services and the Transportation Subcommittee. So I'm going to go ahead and turn it over to our esteemed chairs, Lauren Cardin and Corinne Jones, for the Housing Subcommittee.
Hi, thank you, Sherry. Hi, everyone. My name is Lauren Cardin. I'm the Director of California Housing Advocacy at Justice and Aging and the co-chair of the Housing Subcommittee, along with Corinne Jones, who serves as the other co-chair. First, I want to thank Susan for the recognition at the beginning of the meeting, and I look forward to joining DACLAC in 2026. So we appreciate Sherry and Hagar for pointing out the housing wins we had this year, particularly the continued funding for Home Safe and the increased funding for HDAP. We also appreciated the release of the HCBS non-Medi-Cal gap analysis, which was Initiative 8 on the MPA initiatives, and we're going to focus our comments today on that report. I will start, and then Sherry's going to add, and then Corinne will add her additional perspective as well. So last month in our Housing Subcommittee meeting, we received a great presentation from CDA and Mathematica on the HCBS non-Medi-Cal gap analysis housing findings. We were not surprised by the findings, but we really appreciated that the state has taken the effort to highlight these gaps for people with disabilities and older adults looking to secure housing in California. We wanted to call out a few of the findings and then offer our feedback and suggestions for future actions by the state. So I'm going to focus on two of the gaps that were identified in the report. So the first one was gap 1, which was the lack of affordable housing and shelter access. So the report really highlighted the lack of affordable housing that people with disabilities and older adults on fixed incomes have access to. It's this combination of an insufficient supply and high housing costs that make it challenging for older adults and people with disabilities to secure and maintain their housing. And the report identified 77 housing relating programs that are operating in California. So this was kind of a wide berth of programs, including housing programs that rely on federal funding, like project-based vouchers, housing choice vouchers, Section 202 and 811 funded housing, permanent supportive housing, as well as our state housing programs. And sorry, I may take breaks so that I don't have a coughing fit during this presentation. So for the federal housing programs that were identified in the report, and that's like the project-based vouchers, the housing choice vouchers, and Section 202 and 811. These programs they are available, but they have years-long wait lists in most communities, and they're likely not accessible for people who need to quickly exit homelessness. So this issue was identified in the report, but we just want to highlight that we're likely looking at decreases in federal funding for all the HUD housing programs. And what's particularly concerning is potential cuts to the COC funding. Those are the continuum of care funded programs, so the programs particularly targeted to preventing homelessness. And particularly concerning is a decrease in funding for permanent supportive housing. And while Prop 1 funding will be able to help fill some of these gaps, we're concerned that many counties are seeing Prop 1 money as kind of filling current state and local funding gaps. So the federal cuts would likely still be felt despite this new infusion of money. I mean, I think this is what's happening in all arenas, but just highlighting that it's also happening for our housing programs. And then just to highlight again, federal cuts always tend to hit rural communities hardest, as these communities have less local funding to backfill the needs. So we're particularly concerned about housing in rural areas. So some of our kind of policy suggestions. So we hope the state will respond fully to these threats to housing. We need meaningful long-term state funding for housing programs to allow more older adults and people with disabilities to be able to avoid homelessness. So I think we have been talking about this for many years, but this could be done through low barrier state rental assistance programs, or some states have instituted a state voucher program to kind of backfill the need or support the housing choice voucher program. And we also need consistent ongoing state funding for housing programs so that providers, organizations providing the services to homeless individuals aren't worried about the longevity of the programs each year. We also encourage the state to closely watch the Guaranteed Income Pilot Program for older Californians that was awarded to the Housing Authority for the County of San Joaquin. We talk about rental assistance, but any increase in income can be seen as rental assistance. So this could potentially be an avenue that can assist people with maintaining their housing, even though it is a guaranteed income pilot. So the next gap in kind of the gap one was the report identified that shelters and interim housing may be inaccessible to people with disabilities or who have personal care needs. So the report was really focused on shelters not being equipped to support people, mainly through due to lack of training. But the report lacked information about whether the shelters are physically equipped to meet the needs of people with physical or cognitive disabilities. We believe, just from our experiences on the housing subcommittee, that there are some inaccessibility issues that are not only due to staff training, but due to the physical limitations of the shelter locations, as well as licensing issues that may limit shelters from providing personal care services. So we're hoping the state could be a leader in this, in adopting statewide best practices or guidance for shelters and interim housing for people with disabilities and people with personal care needs. And state departments could spearhead this effort in consultation with people with lived experience. The last gap I'm going to talk about is navigating the housing programs. So this was identified in the report. The report highlighted the complexity of accessing all the various housing programs throughout the state. This would be especially burdensome for the folks who are trying to navigate it, people with disabilities and older adults. Some of the issues with the complexity, or what leads to the complexity, is there are many differing access points. So a lot of the programs identified in the report are accessed through the local housing authorities. As I mentioned earlier, most of the housing authorities have long wait lists. The wait lists are not even open. So unless someone is currently on the wait list, these programs are not accessible or not available to them. And increasingly more housing programs are accessed through the local continuums of care or through coordinated entry. And this wasn't, there are not as many details in the report to kind of show what this process is like for older adults and people with disabilities. But from kind of our experience of the housing subcommittee of the folks who are working directly with individuals, it can be difficult accessing housing programs through COCs or coordinated entry because the prioritization may favor folks who are experiencing unsheltered homelessness, which having that period of unsheltered homelessness could be really detrimental for folks who have disabilities or chronic health conditions or who are older adults. And so we're concerned about how is this prioritization working, and are older adults and people with disabilities able to access the programs that are accessed through coordinated entries to the same degree as other individuals. And then one other point on Prop 1, again, this money will be very beneficial for the community, but it does add additional layers of eligibility, as folks will have to be eligible for behavioral health services to get access to the Prop 1 or the behavioral health services money or housing programs. So we don't have all the solutions have solved these kind of layers of eligibility and the difficulty it takes to access the different housing programs. But I think it just highlights the need for coordination at the state level around the housing programs, and the need to remove barriers. So finding those kind of low barrier housing programs that can be statewide, and can ease the navigation burdens, particularly for the people accessing the programs. So those were kind of our main highlights from our discussions in our subcommittee meeting. I'm going to pass it to Corinne now to speak about the barriers that she is seeing on the ground.
Thank you, Lauren. So from my experience at Senior Network Services, working with primarily older adults, but as well those that are disabled, I want to put on our minds the who and the what when we're talking about on-the-ground barriers to housing. So my description, based on my experience of the who, is an age range of 60 to 85. The individual is typically single, a single female, never married, divorced, or widowed. Ethnicity is primarily African American, Latinx, or another minority. There's a language barrier. There's often low educational level. The persons are often underemployed or were underemployed. They're disabled. And there are comorbidities, typically cognitive impairments, developmental disabilities, heart issues, or things like diabetes, and there's mobility limitations. So the what of the barriers to housing, and this is what makes it more troublesome, is that the number one thing I see is ageism. That's a perceived lack of qualifications or the ability to handle one's own housing. Beyond that, there's a lack of availability of low-income housing. We know that. Lack of awareness of low-income housing. Lack of transportation to get to vacant housing or to get lists of housing that may be available. There's limited desire to leave areas that somebody is comfortable with. There's a lack of desire to move away from family or friends. There's also a fear of living alone. There's a lack of understanding of the processes to get a house. There's a lack of funds for first, security, utility deposits, and all those types of things. There's a lack of credit history, a lack of desire to present as being on the dole. There's failure to understand and respond to multi-layer requirements to qualify for housing. There's an inability to manage finances, quite often in general. There's a lack of wraparound services to handle the issues of life. Also, a lack of housing in the areas where older adults may want to live, or those with disabilities. And sometimes it's something as simple as not having furnishings, household goods, things that we take for granted, like linens for beds and that, or beds, things like that. Now, this is not an all-encompassing list, and I know that. But these are some of the things when we're talking about, well, I've got this person a housing voucher. What comes next? And it's the on the ground, every day looking in someone's face who says, well, I got my voucher. I qualified for my voucher. But you put together the 8 things of who we're talking about and the 16 things or so that I've listed here of what we're talking about. And those are ground level barriers that we need to work towards overcoming, work towards getting out into the forefront of our housing processes. And many of these people are what we call housing insecure. They may have a bed in someone's home. They may have a room in someone's home, but having a place that they can always, as long as we can be certain of anything, call their home. And their housing is where we need to be focusing, I think, more so than anything else. Thank you. Back to you, Lauren.
Oh, yeah. Thank you, Corinne. We wanted to open it up now to see if any other members of the Housing Subcommittee want to make comments. Okay, Kim.
Thank you, Lauren. My name is Kim Mills. I am a provider of the San Diego Regional Center that receives funding from DDS. And my company's name is A Better Life Together. We provide independent living and supported living services to adults who live in the community. And there are barriers. I reviewed this in our housing subcommittee, I was a little worried because I kept saying older adults or people disabled adults, and I kept thinking, what about people with intellectual and developmental disabilities? I never see that, and I when you read further, it talks about physical disabilities, people with significant behavioral, cognitive, and intellectual needs, but it's never clear about the IGD community. So hopefully going forward, I've been on this committee, this full committee and the subcommittees for years. I always feel like I have to bring it up and just make sure we're not forgetting about this huge population. Just looking at now the stats on the dashboard, I see Director Savinka on here from DDS, over 500,000 people that are served. And a lot are adults that want to live in their own homes. So when Corinne talks about barriers, sometimes landlords don't think that they should be in their own homes. And so as a provider, us going around trying to find housing for these individuals, that's a barrier, or how they're going to pay their rent. So as an agency, we provide a lot of the quote unquote wraparound supports, trying to convince them they will get paid, you will get paid. But a lot of the barriers are they require a lot more income than what these individuals make. And so we're already facing an uphill battle. So I am concerned about whether or not these individuals were even considered in the findings of the gap analysis. I'm sure a lot of work was being done to put all this together. But I always get worried when I don't see our population in the writing. I don't understand what I don't understand. Maybe they are, or maybe they're not. But I'm hoping that as we continue on with this, we'll definitely spell it out and make sure we're not forgetting over 500,000 people who need the same services, who are on Medi-Cal, who experience the same discrimination and some of the same barriers that the aging and a lot of them are aging. We serve two individuals that are in their 80s, and so then they cross over, and a lot of them are on Medi-Cal, and even accessing a lot of those services, like rental supports and things like that, we have a hard time. And so there's a perception that DDS and Regional Center takes care of stuff, and they provide access for services, but not necessarily, they don't pay rents and things like that. So I just want to make sure we're always included in these conversations. Thank you.
Yeah, thank you so much, Kim. If there's no other comments from subcommittee members, we can open it up to the full committee. So, go ahead, Jeff.
Yes, I am unmuted. Okay, thank you. I may be reflecting my own level of ignorance here as opposed to others, but when I think about housing in comparison to how well informed advocates are with respect to, say, transportation or long-term care, it seems to me that housing we have a lot lower level of information in terms of what programs are around, what people can take advantage of, et cetera, et cetera. I wish they were like a resource or two that would sort of enable people without having the level of expertise that your subcommittee does to sort of have a better understanding of the housing landscape.
Yeah, I think that is so necessary, and I'm not sure the resource exists because there are so many different funding streams, and particularly in the last 5 years, there have been new funding streams that have developed. And so like for advocates and for the folks helping people access the programs, it's even confusing navigating the system. So yeah, I really like the idea of having some kind of resource that shows like these are all the programs that are available, these are where to access them. I think that would be helpful.
Okay, thank you. I'm not surprised at the answer, unfortunately.
Yeah.
So just a huge thank you to our housing subcommittee and Lauren and Corinne, your work. This is a really excellent kind of deep dive into the HCBS gap analysis. And we really appreciate the time people take to read it, to think about it, to make recommendations back to us, because really this is for everybody. It's not an analysis just for us. And I think that we need to really think about these issues as we build out the roadmap, because our next steps are by the end of next year to build out a roadmap for how we approach building out capacity in the system across housing and transportation, as well as all the other non-Medi-Cal HCBS that are in the scope of the study that we did with Mathematica. So that's the first thing. The second thing is this issue of navigation, and it's so important. And I know that the solutions to this housing issue are it's very complicated, it's resource intensive, it's difficult because we know that it's not a one silver bullet that's going to solve all of our problems. But I do think this issue of navigation, I experienced it myself trying to help an older adult who was at risk of homelessness in the Bay Area. And it wasn't until I reached out to Sherry that she was able to help, because she was able to help the individual understand the services in that area through the support of the Silicon Valley Independent Living Center. But one concept that we're really interested in, that we're piloting in a couple of our grants that we have right now, is this issue of a community health worker as a navigator. And we're also trying to look at the sustainability of it through the Medicaid funding stream, as well as Medicare, because Medicare has a little bit of reimbursement, code reimbursement for some CHW services. So I do think we appreciate that input, and it's something that's on our radar, and that we're going to be trying to see how we can expand access to CHW services, specifically as navigators of our system, but also this issue of kind of a micro credential in maybe housing navigation. So I don't know, Anna, if you want to add on to that, because you were the one that kind of brought to me this concept of a potential housing navigator, CHW.
Yeah, I mean, I think there is just, this need, we've heard it so many times. I've experienced it. We all have, in trying to really, get the resources that are available and to be able to navigate people to them. And so how do we develop housing navigators that are able to understand, as Lauren said, the many different programs and services, where the entry door is, what the eligibility is, and help get people there. And I know there are local communities, organizations that are doing some of this work. So part of it is like, who's doing it? What are the best practices? And then what are the resources that could be leveraged to get people dedicated to housing navigation? Is there opportunity with BHSA? Is there opportunity in other areas to leverage through Medi-Cal or Cal-AIM to be able to help people get access to those services and supports?
Michelle?
Yeah, hi. I think this is like transportation and other services. It's so many different avenues of access, and some coordination of those services. I think, and what's been said is very important. And I'm glad that the state and you as upper officials are starting to listen and hear that. But this is a need that's been unmet for a very long time. And some of that navigation, whether it be for seniors or people with disabilities, is long overdue. And when a unit opens up that has accessibility features, then it should go to somebody who needs those accessibility features. And a lot of times that does not happen. These lists that are 2 years or longer to wait to get on, it's important that we understand that that's not meeting the needs of a lot of people. Thank you, guys. Thank you.
Yeah, thank you. Debbie?
So hello, everybody. Good morning. My name is Debbie Toth. I am with Choice in Aging, and all you can see on the screen is a blurry background and a lot of really white hair, and maybe my pink lipstick. So that's me. I am wanting to first, thank you both for your incredible leadership in this space. I also just want to highlight that the traditional systems that we have, we know are not working. And we throw a ton of money at housing, and we don't think outside the box about ways that we could capitalize on what we have existing. There were a lot of lessons to be learned in the pandemic that we have magically forgotten about how we utilize existing spaces and fund programs and services inside existing buildings, for example, old hotels. Like, there's all these different things that are out there. What we also don't talk about is what Corinne highlighted in terms of having services on site. So she mentioned transportation as a barrier. When you have services on site, which include transportation, you don't have to worry about that. We have to be thinking about not just the house. We have to be thinking about how people stay living in that house. And so to the extent that we can think about shifting policy from building housing to building campuses that have health, social, transportation, nutrition, all of those things, because once somebody moves into a place, we talk about aging in place. How are you going to age in place if you don't have the support available to you where you are? And so I just wanted to highlight, I mean, we're trying to do it at Choice and Aging, but because all the funding goes to housing and nothing goes to services, we are in our 5th year of trying to raise money to build this aging in place campus where we can make it a replicable model. We can study our outcomes. We can prove this is the right way to do it. But why should everybody be going homeless and being institutionalized at higher taxpayer dollars in the interim? So I just wanted to launch that out there and deeply thank both of you for your work. Thank you.
Yeah, thank you for that, Debbie. That's so true. Andrea.
Hi, thanks for all the great information. So I just wanted to let you guys know that, in all honesty, you have people within your community. You have consumers like myself that is very knowledgeable and very do a lot of research, and a lot of time we are underutilized. And there is a disconnect that need to be addressed because the resources are there. In regards to housing, HUD right now has a list of houses all around the country in regards to subsidized housing, Section 8 housing, public housing, and it's like a really large map. But sometimes folks don't know about those services. So I would really encourage folks, if you're working with advocates and consumers, to really utilize that resource because we're unutilized, and it's very frustrating because we have the knowledge. A lot of us worked, professionals, speakers, advocate, and we're just not utilized. And so a lot of these services are out there, and sometimes, having the resources and the understanding, it's out there. So I would hope, Susan, that with this new committee coming on, that you really utilize the folks that's on those committees because they work tirelessly to help their loved ones, themselves, their communities with these resources. So they are available, but we need to really start utilizing the folks that's on these committees, because I would definitely say that I have been definitely unutilized. So I would definitely encourage you moving forward to utilize the resources that you have.
Yeah, thank you for that comment. And kind of to address the earlier question about the kind of the map of all the housing programs, it probably lives inside the heads of the local advocates who are so skilled at navigating the systems. And once connected to someone who needs the housing, can help them, access all the resources that are needed. So thank you for that. There was a question in the chat, which I'm not sure of the answer to. If anyone wants to address it, it's just who is currently working with Medicare and what are those billing codes for community health workers for housing navigation?
So we, as part of our Cal Community Connect grant that we got from the Administration for Community Living, are really excited to be working in partnership with some of our local area agencies on aging, as well as Futuro Health, with the support of some of the MPA Foundation partners, to really not only stand up a community health worker navigator position, but also to see how we can bill Medi-Cal and Medicare for it. So that's something that we will be doing, but we're kind of at the early process of it, to be determining, how we can develop a sustainable model, because we know that the general fund is not the place that we can, look to at this moment. So I hope that answers the question.
Corinne can go ahead.
I do want to share that sometimes we have to be mindful of the difficulties of housing in particular areas. I'm in Santa Cruz, and where typically renting a room could run as much as $1,800 a month, because Santa Cruz is just very, very, very expensive. I have a full-time housing navigator, and unless somebody comes to him with a voucher, it is extremely difficult to find a placement for them. If they have a housing voucher, we can get them, all day long, we can find a spot. But the voucher waiting list is years long. And so until and unless we can find a way to either get folks to do shared housing type of ideas, or other ways to get down the amount that housing costs, and make consumers more friendly towards other consumers. I just don't know. I don't know what the ultimate answer is, but the biggest deal is it's so expensive in certain areas. If I were to try to house someone in Merced, or to house someone maybe in Salinas or Soledad or somewhere, it would be way, way easier. But in Santa Cruz, it's just like you're bumping your head on the wall and just going, oh, I hit myself again. It doesn't happen easily.
Any other comments? We just have a few more minutes. Okay, if not, thank you everyone for all your feedback. That was, it's really helpful to hear from everyone and the different issues you're seeing in your communities. So we thank you for the robust discussion. I just want to thank the state again for the report, for highlighting the housing challenges of people with disabilities and older adults. And yeah, we always welcome more engagement on the housing subcommittee. So thank you all.
Thank you, Lauren. Thank you, Corinne, and the Housing Subcommittee members for the excellent work that you're doing, and for that wonderful summary and discussion on where we're at and where we need to move. And it was lovely to hear all of the engagement too from DACLAC members. I'm going to turn it back over to Carol, because she's going to lead us into our public comment period so we can hear from everyone else. Carol?
Great. Thank you, Sherry. Hello, this is our public comment period. If you're joining by phone, you can press *9 and that will indicate to us. And if you're joining by the Zoom webinar function, you have a raised hand icon. If I could just remind, we're eager for all of your public comments, 2 minutes each. Also, if you have comments for later in the agenda, like HCBS, we'd like you to hold those comments until after that presentation. So if you could keep your comments to what we've covered already, or anything else. So we have Connie Arnold. Connie, I'm going to unmute your line. Go ahead, Connie.
Thank you. Connie Arnold, disability rights advocate, 35 plus years. I just want to thank you for having this meeting, and I want to comment on a few items. One is I'm opposed to the managed care, the carve-in of waivers into managed care, for the reasons outlined by a letter sent by a number of organizations in September to DHCS. On the housing issue, accessibility is critically important for people with disabilities and often forgotten by counties when they're making plans and building housing. And yet, the majority of people have disabilities that are in need of housing who are homeless. Additionally, one of the core issues I would say that your missing here in the discussion is the fact that from the beginning of time, SSI has been a disability benefit that the amount of money that is given is too low, and it's basically enforced poverty from the time you're an SSI recipient with an inability to often escape SSI, despite a number of programs working disabled and various programs. It still remains a difficult path for people to escape poverty. I think it is a good idea that you're talking about the shared, you're talking about living with housing with supports, and that is a key important role in keeping people in the home and out of institutions. In order to do that, you need to emphasize a parity in wages for providers between institutional care settings and home and community-based services. Without that, you will still steer people towards institutional care. And those of us trying to find caregivers that are on IHSS or a waiver that pays the same rate are finding it for decades extremely difficult to find anybody competent to work for us, particularly those with complex care needs. Thank you.
Thank you, Connie. Let me turn off this. Sorry about that. Thank you, Connie. We're going to go ahead and go to Lisa. Lisa Cooley. You can unmute your line.
Hello, my name is Lisa Cooley. I think that people that are in the forgotten middle, and those are people who make too much money for Medicaid funded home care, and also people who do not have enough money for private home care. I think there needs to be a program for seniors and people who have disabilities who need home care to have another source of money to pay for home care that isn't always IHSS Medicaid funded home care. I also think that getting affordable housing vouchers needs to be simplified for people who have disabilities and for seniors. Thank you.
Thank you, Lisa. Priscilla. Priscilla, you can unmute your line.
Good morning. I really enjoyed all of the presentations this morning. I especially enjoyed Corinne's. The points that she brought up were so valid for the issues that people who are in housing. As a career, I was an occupational therapist and did home health for many years. And I would find sometimes when I would go into someone's home, they would have nothing. You know, they didn't have dishes, they didn't have bed sheets, they didn't have towels and the basic things. And so I'm wondering, as the caseworkers find housing, sometimes we would lock into certain churches, certain volunteer organizations who would have a house full of items ready when housing was found. So I'm wondering if some of the caseworkers have investigated that to provide the household goods when a housing is provided. That's all I wanted to say. Thank you.
Thank you, Priscilla. Thank you so
do
much.
a wonderful job for the aging population in California.
Thank you, Priscilla.
Yes.
This is the public comment period. If you have a comment and would like to raise your hand, please go ahead and do so. And do know that you can send your comments at any time written to our Engage email box at engage, ENGAGE, at aging.ca.gov. We monitor that email box and will certainly welcome any comments that you submit to us. Give a final call for any, oh, we do have Lisa. Okay, Lisa, go ahead and continue your comment.
There also needs to be more collaboration between area agencies on aging and services for developmental and intellectually disabled adults related to housing and senior services. Because as one of you said, and I don't remember who said it, in certain parts of California, there's a lot of overlap between IDD services and services for older adults. And I think there needs to be more collaboration between our service systems instead of less, to help seniors who are not only seniors, but seniors who have disabilities get easier access to the services they need to stay not only safe in their homes, but independent in their homes and communities.
Great, Lisa. Thank you for adding that on. Well, Sherry, that was I don't see any more hands.
I don't either, and we have a break coming up, so I guess we can start early if we don't have any more comments from the public.
Yes, let's go ahead and put up the break slide. And I do want to do a personal shout out to our ASL interpreters. They're doing a great job at transitioning and keeping the interpreting going seamlessly. So thank you to Heather and Rex. So that's just my personal thanks. We have 15 minutes. Let's call that coming back at 11:35. Is that okay, Sherry?
That sounds great. We're right on schedule, even 2 minutes early. So
great. Thank you, everyone.
Thank you. We'll see you at 11:35.
It is 11:35. It looks like we have a lot of cameras on. If you could turn your camera on and you're ready to go. And for those who have, if you could just double check your name display, and if it says DACLAC member or guest, can you change to your name so we know who has joined us? And if you need help with that, CDA team is happy to help.
Thank you, Carol. So the HCBS subcommittee has been preparing today for the Department of Healthcare Services presentation that I believe Joseph Billingsley will be giving us about the department's plans to transition 4 of our 1915C waivers into managed care delivery. So we are going to first listen to Joseph's presentation, and then we will have 5 committee members who are going to present their reaction. We have some pretty great people on the committee that wanted to speak up today, representing a variety of different points of view. So I'm really excited about this presentation, and I'll go on mute now, and go ahead, Joseph. Welcome.
Thank you, Agar. Really appreciate the chance to attend DACLAC again today and be able to provide this update to everyone. We think that this is an important forum for allowing us to continue to keep stakeholders updated on the work that we are doing at DHCS and with our partners at Department of Aging and Department of Public Health in really working to plan towards HCBS integration, Medi-Cal HCBS integration into managed care. Just before I dig into the presentation, I do want to take a moment on the front end to acknowledge that DHCS, has received a recent letter from a large number of stakeholders sharing concerns about the HCBS integration into managed care. I heard Connie, I believe, referenced it earlier during public comment. We appreciate that letter. We take stakeholder feedback very seriously. And so we are taking time to review the specific concerns that were raised in the letter very carefully. These are concerns that we want to continue to work with stakeholders to address as part of this planning process. We're really grateful for the engaged stakeholders that we have here in California and need to hear specific feedback about the integration work that we are planning. We can't do that in a vacuum. We need to do that with stakeholders. And so as part of that, we're committed to ongoing stakeholder engagement and transparency throughout this process. And so I just want to add on there, we're going to talk more about it during this presentation, but just really making that point that it is, it is essential to our planning for this integration, that it is informed by stakeholders, including members with lived experience. DHCS and our partners at Department of Aging and Department of Public Health have seen tremendous value in the feedback that we've received from the focused stakeholder work group that kicked off in May to help inform and vet concept planning for the HCBS integration, as well as feedback that we receive in the regular updates that we provide in stakeholder forums like the DACLAC committee. And I just also, want to be clear that we are committed to continuing and expanding these work group meetings throughout the concept paper development process. So we have meetings scheduled right now through the end of this year, but that is not going to be the conclusion of the work group. We're going to be continuing the work group, continuing meetings as we go through the concept paper development process, and then following that, past that, as we move into readiness and operational planning, we need to have that continued ongoing dialogue with the work group and as well as our broader stakeholder community, because we recognize there's a lot of topics that still need to be discussed and also topics that require further discussion. Okay, maybe we can go ahead and move on to the next slide, please. So, and some of this is slides that we've gone over before, just because we want to continually make sure that we're rebasing for everyone what we're doing here and what our goals in the process. So, again, what we're doing, we're working to plan towards integration of select HCBS current HCBS waivers into our managed care delivery system. And we think that's really important in working, aligning with our CalAIM goals and continuing to work towards fully centering the care of individuals and really working to address the whole person care needs of individuals with a single entity, the managed care plan, working through its network and ensuring that it has sufficient network to be able to provide all these services and coordinate the necessary services for members. And so goals that we have in this effort are strengthening California's success in rebalancing its long-term services and support system towards home and community-based services. And this builds off of the recent carve-in of institutional long-term services and supports into managed care, integrating HCBS into managed care will give the plans the ability and incentive to offer members alternatives to institutional long-term care placement. This will also better position plans to integrate and coordinate members' long-term service or long-term support needs with their other health services, with a goal of making the system easier for members to navigate and ensuring that all of their care needs are smoothly coordinated across the continuum. And then also it's important to that integration will place accountability in one entity, that being the managed care plan, for ensuring high quality outcomes for members, including access to services, quality of care, and cost management. And it also helps create greater financial predictability of HCBS costs for the state by including those costs and capitation rates paid to plans. Next slide. So again, what are we doing here? We are want to always make sure we're being clear when we talk about HCBS integration into managed care. What does that mean? Because there are a lot of different HCBS programs. So we are talking specifically about integrating 4 existing 1915C HCBS waivers into managed care. And those 4 are the Multipurpose Senior Services Program waiver, the Home and Community-Based Alternatives waiver, the Assisted Living waiver, and the Medi-Cal waiver program, which is formerly known as the HIV/AIDS waiver. Also want to be very clear that when we are talking about managed care integration, we are not, that does not include the IHSS program, the In-Home Supportive Services program. That is not part of the planned HCBS integration into managed care. It also doesn't include the 2 1915C waivers and 1915I state plan option that are administered through the Department of Developmental Services for individuals with intellectual and developmental disabilities. However, noting that those services do still require coordination with managed care, and so we have been working to accomplish improve that coordination through efforts like the memorandums of understanding that we've been working with managed care plans to have them execute with different entities like regional centers and the counties. Next slide. So we've been using several strategies to ensure that really robust stakeholder engagement that I was emphasizing earlier to engage stakeholders on the direction of managed care integration and the multi-year roadmap. First, we launched a strategy committee made up of representatives from across the DHCS, CDA, so Department of Healthcare Services, Department of Aging, and the Department of Public Health last fall in 2024 that met regularly on initial program design and implementation concepts. From there, we then launched the HCBS integration work group. We started advertising that in April of this year and launched that at the end of May, beginning of June, to really begin that focused work group effort to gather feedback on the integration of select Medi-Cal HCBS programs into managed care and vet concepts that we are proposing. This work group includes 23 members who represent a variety of organizations, interest, and experience, with the waivers proposed for integration, including individuals with lived experience, receiving services from Medi-Cal waivers, caregivers, managed care plans, managed care plan associations, home and community-based services providers and provider associations, policy experts, and advocacy organizations. The HCBS integration workgroup meetings are closed to the public to allow for candid discussion, but materials from the meetings are being posted to our website. I'm pleased to be able to state that we've gotten past some hurdles that we had, and so we've now begun posting those materials. I will put the link in the chat at the end of my presentation, and also be sharing some key takeaways from those workgroup meetings later on. And then additionally, we continue to provide regular updates on the HCBS managed care integration planning efforts during established meetings like this one, and other stakeholder forums and provider forums and managed care plan forums, so that we're continuing to keep the broader stakeholder community informed on this effort, and having those forums for receiving feedback throughout the process. Next slide. This just demonstrates some key milestones since we started this work, and as we our pathway for continuing. Throughout 2023 and 2024, we engaged stakeholders to inform the gap analysis report, which was published in February of 2025. And then using, following the publishing of the gap analysis report, that was the Medi-Cal HCBS gap analysis. We, in looking at those results, the Department of Healthcare Services, Department of Aging, and Department of Public Health initiated our HCBS integration planning in the fall of 2024, and established preliminary direction for the integration during a leadership summit that we had in January of 2025. In March, we put out the call for nominations for the HCBS integration planning work group, which began again late May and early June. And then also throughout this time, we've continued attending public forums to keep broader stakeholders informed. In January 2026, we will hold an additional leadership summit on design concept decisions for the implementation approach before drafting a concept paper for CMS. The concept paper will outline DHCS proposed transition of these selected waivers to managed care, incorporating learnings from discussions like this, the HCBS integration work group, and decisions made by our leadership. And then also, as part of the concept paper development efforts, DHCS is also convening regular and ad hoc internal meetings with DHCS divisions and staff from our sister departments to strategize and consider design options for the HCBS integration. Those conversations help inform the conversations and topics we discuss with the work group, and vice versa. The work group also helps inform where we need to have additional internal strategy sessions. And then HCBS planning, integration planning work group will review the concept paper in summer 2026, and it will be submitted to CMS for consideration in fall 2026. It will also be released for public comment around that time when we're submitting to CMS. And then in winter of 2026 and past, we'll then be working to, really shifting into operational and readiness planning, finalizing the roadmap, and beginning work on just all the readiness work, contract updates, amendments, waiver applications, amendments, etc. Next slide. Again, as we discussed earlier, 4 of the existing Medi-Cal HCBS programs are planned for managed care integration. Currently, there are key differences between the programs, including population served, services covered, enrollment gaps, or enrollment caps, and average per capita cost targets. And so as we think about managed care integration, we also want to point out that HCBS waiver programs have services that are different from other benefits covered by managed care plans. And managed care plans will need to modify their operations accordingly to adjust for that. We are considering two options for integrating the four waivers. The first option we are referring to as a lift and shift approach. Would involve lifting the four existing HCBS waivers as they currently operate from a fee-for-service delivery system and simply shifting them to a managed care delivery system by concurrently operating the 1915C waivers with the state's existing 1915B managed care waiver. The populations in that option, the populations and services under each waiver would stay the same. We're also considering a second option, which would involve blending the waivers into one or more new 1915C waivers, which we are referring to as de novo waivers. These de novo waivers could include some combination of existing waiver services, but also really provide a blank slate for DHCS, CDA, and CDPH, working again with stakeholders to resolve issues previously identified in the gap analysis and with how the current waivers operate. The second option is currently the HCS preferred approach, and so we'll discuss more how we're moving towards a decision on this. Next slide. So again, discussed that we're considering two approaches to the integration, and to determine which approach to use. We've been working with key partners and the work group to build out the concept and determine its feasibility. This has included work to develop an initial design for the de novo waivers, such as what services and populations to include, and develop assumptions about how the de novo waivers would share the supply and demand for services. And these initial design assumptions are being used to conduct, DHS is currently conducting a fiscal analysis of that de novo waiver option. And the results of this fiscal analysis will help us evaluate the two approaches and refine the design of the de novo waivers based upon considerations like state budget conditions. Next slide. I think if you go back one. Okay, yeah, thanks. So just a few additional updates that we can share about our decision making over the last few months. One, we plan to use the 1915C waiver authority concurrent with the state's existing 1915B managed care authority to integrate home community-based services into managed care. So it's called referred to as a 1915BC combo waiver. And to ensure members do not experience gaps in care, we're planning to implement enhanced continuity of care protections and requirements for current assisted living waiver, home community-based alternative waiver, Medi-Cal waiver program, and multipurpose senior services program enrollees to maintain their current waiver services during the transition period to managed care. And that involves requiring managed care plans to contact non-contractor providers prior to the transition to achieve time-bound continuity of care agreements for the members that they'll be serving through this integration. And then it also requires managed care plans to automatically continue authorized services for a set period of time, which is a minimum of 12 months. And this is known as enhanced continuity of care for services. Next slide. So we've covered a lot of ground in our meetings with the work group so far, with a particular focus on discussing the de novo waiver concept and assumptions that we just discussed. To date, we've convened 8 sessions between April and August. And in those, we've discussed with the work group federal authorities for implementation, maintaining or blending current waivers, considerations for statewide integration, populations that would be served by the de novo waivers, member supports to ensure continuity of care, service packages and service definitions for the de novo waivers, and also anticipated changes in service use and provider availability under the de novo waivers. For those that are, again, interested in seeing more of the content that informed these discussions, the work group meeting materials and updates are being shared on our new HCBS integration webpage, which again, I'll put the link in the chat. Next slide. And that's the link, but I'll again put that into the chat. If you can go one more slide, please. Great. So obviously can't capture the entire breadth and depth of the work group discussions in our time here today, but just wanted to take a moment to flag a few cross-cutting items that have emerged in recent HCBS integration planning work group meetings. Work group members have emphasized that HCBS integration should prioritize advancing a few key issues. First, where waivers or waiver services are currently limited geographically, it's critical to expand that availability statewide. DHCS has established this as one of the goals of the de novo waiver concept. Also, finding an approach that allows for increasing waiver slots overall is another priority. So, I mean, one of our stated goals, another goal in this, in addressing like the HCBS gap analysis, is increasing, is HCBS integration to managed care is a way to increase access. And part of that is, you know, how are we increasing access to the number of people that can get these services? Members also want an approach that reduces system complexity, including complex eligibility and enrollment processes, and you know, really communicated that it's important to find a balance between increasing standardization and still maintaining specialized care for specific populations, like children are members in the Medi-Cal waiver program. Work group members also raised considerations for integration planning, such as the importance of managed care plans partnering with knowledgeable community-based providers, ensuring appropriate oversight of managed care plans, monitoring quality and compliance, and assessing plans' readiness for the transition, and setting a timeline for the transition that allows ample time for relationship building, contracting with small HCBS providers, and data sharing between providers and managed care plans. Next slide. One more. Thanks. Just quickly, this is just, again, recognizing that point that we still have a lot to talk about and things that we need to talk more about. So this is just a sampling of the topics that are planned for discussion in the upcoming work group meetings, those that are already scheduled and those that are going to be scheduled, as well as any other breakout meetings or small group or small committee meetings that we need to add on. That includes data systems and data sharing, enrollment caps and waitlist policies, provider enrollment and supports, payment models to incentivize quality care, managed care plan readiness, quality and oversight, HCBS network adequacy standards. That's a big one. We know there's a lot of emphasis on that from our stakeholder community, and case management roles and responsibilities. And again, these topics are fluid, and we're continually actively working with our work group members and leadership to identify the most critical topics to cover next. Next slide. So just next steps, we're the HCBS integration planning work is actually reconvening tomorrow, this week. So it's the next meeting is tomorrow, and then we're continuing to meet monthly through the end of the year. but also looking at opportunities to add additional meetings, as I mentioned, and we'll be continuing these meetings into the new year, like as we go through this process, through concept paper development and and as we shift into operational planning and readiness planning. Okay. I think that about covers it. I want to hand over now back to Hagar so that we can give time to the reactor panel.
Thanks so much, Joseph, for the presentation, for all your hard work on this. And I'm going to just introduce the reactor panel. Sylvia Yee is a public policy director at Disability Rights Education Defense Fund. Kim Mills is the CEO of A Better Life. She's a waiver provider. Nina Weiler Harwell is an associate director at AARP. Michelle Rousey is a consumer and a Medi-Cal managed care dual eligible member. And Joanna Glum is a family caregiver and also a managed care member. So thank you all for preparing your remarks here. And I'm going to go on mute and turn it over to Sylvia.
Thank you, Hagar, and thank you to DHCS and to Joseph for going through the slides. I'm just going to start speaking and go on to the panel. My first thought is that the gap analysis on which this plan is based looked at data that often seemed to be aggregated among all plans and focused more on such systemic barriers as cost, availability, coordination, communication, and navigation, and those are important. But there was little or no evaluation of whether each managed care plan found and addressed unmet need. Knowing and meeting existing unmet need, however it arises, as well as clearly foreseeable unmet need, such as the need which arises, for example, when an aging spouse or parent is a caregiver but is also experiencing more healthcare needs for themselves, is at the crux of ensuring that this managed care transition doesn't harm people who rely on long-term services and supports. Second, because of this absence and the underlying gap analysis, there's little or no concrete connection between the plan to integrate home and community-based services and long-term care into managed care and the articulated goal for the initiative to close those gaps that are identified in the gap analysis. People with disabilities, older adults, and advocates need DHCS to demonstrate that managed care plans are capable of closing those identified gaps, that each one has already successfully done so using the tools they have now, and that there are enforcement mechanisms in place to hold them accountable. This is particularly important now, during a period of regulatory and funding chaos. We need to put in place more comprehensive data collection for monitoring and oversight. We have to have a way to constantly monitor in real time or close to it what is happening to the people who are falling through the gaps and not just have a description of the gap. We need to be able to pause the transition in any county when needed and fix systemic issues throughout the integration to ensure that people relying on home and community-based services and supports are not harmed. This integration will help DHCS delegate responsibility for home and community-based services without the kind of detailed oversight, enforcement, and data gathering that will ensure plans will be a true backstop for people on waivers and using long-term services and supports. And later in this panel, Nina will look more closely at the existing data shortcomings and issues and what they reveal. And finally, we continue to be deeply concerned that most managed care plans have no idea how complicated the lives are of people with complex conditions and home and community-based needs. These individuals have healthcare and home and community-based service needs, constant scheduling needs, abundant paperwork requirements, issues arising around coordination of services and denial of and payment for services. There are significant gaps in access to managed care delivery services now, not only HCBS and community services, but also medical care and durable medical equipment. Michelle, Joanna, and Kimberly later in this panel will further illustrate just how detailed and in the weeds plans must get to ensure that people with complex care needs remain stable. Again, there is no clear evidence that plans are even fully using the capacity they have now to fill home and community-based support needs. the slides indicate that enhanced mandatory continuity of care services will be mandatory and that plans must contact current providers. But there is a known issue with plans being able to establish smoothly working contracts with established providers and make sure that billing works. A contact is not a guarantee of a contract. How will these known barriers to effective continuity of care be addressed? Plans have not been historically required to provide home and community-based services and supports, yet we are jumping now from plans being responsible for optional services to full responsibility for home and community-based services and supports that are not optional in any sense of the word. If managed care plans are not addressing existing gaps now, how will DHCS expect plans to close gaps in new integrated services? How can managed care plans not have to demonstrate a present readiness and functioning provider network in place for providing home and community-based services and supports before they shoulder additional big responsibilities? And I'm going to now hand that off to Kimberly.
Thank you, Sylvia. Ditto to what all you said. I think you covered it all. I am a provider with the San Diego Regional Center. I serve adults with intellectual and developmental disabilities and providing supports to them in their own homes in the community. So I'm under the HCBS DD waiver. We also serve individuals in self-determination. And so my concern is now we will be required to coordinate with these managed care plans or regional center. Regional center coordinates. We receive services, referrals from the regional centers. They coordinate services. We coordinate a lot of services. So now it sounds like it might be just another step to coordinate services. So I'm not quite sure what that actually means. And I just think about it as another barrier to the work that we already do, trying to find homes for individuals. As I mentioned before, there's over 513 individuals within the IDD community. And of course, we're maybe not talking about all, but I think about the stress that the families are under self-determination, and the stress that providers are under, really just trying to navigate the system as is. And I wonder about the capacity, as Sylvia pointed out, of the managed care plans that probably have their own ways of doing things to be able to take on yet more. And so I'm just concerned about the timeline. 2028 seems far away, but it's really not that far away. And again, given the state of affairs in the world that we're all living in, it seems like maybe more work needs to get done. Not to downplay all the great work that has been done, and I'm sure the work group is capable of navigating all these things. But I just wonder about the population that I'm involved in on a daily basis, and now it sounds like even more work on providers who are desperately trying to just meet the needs and ensure that individuals within the IDD community receive support so they can live the lives that they want to live in their own homes in the community. Thank you. And I'm not sure, Hagar, who I turn it over to.
I believe Nina is next.
So good morning, everybody. I'm Nina Weiler-Harwell with ARP California, and really appreciate the opportunity to speak today. I'll try to abbreviate my remarks. But first of all, Joseph, thank you for sharing the goals and purposes of integrating the waivers into the managed care plans. We do have concerns, as you know, but I do today want to focus on the growth in community services supports. Notably, I really want to say there's been some wonderful happenings in some of the supports, like medically tailored needs and housing tenancy and unsustaining. So some counties have done really well and have delivered many, maybe all of the 14 optional community services, but that's not really true in most counties. And what we see looking at the data is that and this is the 2024 data, high service provision was clustered in maybe a dozen counties. And I'm not going to shout out names, as tempted as I am. But there are some counties who are really able to stand up these supports in what seems to be a significant and meaningful amount. So when we look at the 2024 data, you can see in many counties that many services simply were not available. So, for example, we talk about housing supports, housing deposits. One of the communities has really not shown significant numbers or growth from what we can make out. And it's so wonderful that individuals in such high need can receive the housing tenancy and sustaining benefit, but not having access to assistance with housing deposits could be posing yet another barrier to accessing the full suite of housing supports. I'll also call out caregiving supports just because this is such a big issue for ARP. Our members really look to us for caregiving assistance and guidance. We have 4.4 million family caregivers in California. I understand not every Californian is in CalAIM, but those are the individuals literally who are the backbone of our system of long-term services and supports. They are personally and individually and in a group keeping older persons and individuals with disability out of institutional care. And yet, if you look at the data from 24, this was unavailable to caregivers of members in the vast majority of counties. And we only see about 9 counties providing that service. And we see a similar concern around nursing facilities transition, where only 11 counties or providers were offering that service in 24. So this is just a snapshot. I don't mean to downplay the critical importance of so many other services. But this really does, again, exemplify the concerns about this transition in just 2 years of these critical waiver programs providing services and supports to individuals with the highest needs, moving into these plans that have so far not demonstrated, many have not demonstrated plan readiness. And so I do have a few questions, and I'm happy to have a separate conversation. Is Department of Healthcare Services actually collecting data of the actual need for member need for services in each county / provider, and analyzing the level of met and unmet need? And if so, when would that data be available? I think this was raised before and I may have missed it, but what is the plan for mandating that each of the community supports become mandatory? I repeated myself there. When exactly is that happening? Because that needs to happen soon in order for these plans to be ready to take on these high need individuals. So that really brings us to where looking at, I already asked this, will the plans be ready to provide these services to those in 1915C waivers? I brought up nursing facilities transition because if you're going to move assisted living waiver in, well, those plans need to be ready. And so far, at least through 24, when I looked at the data, I didn't see readiness. So again, this is only meant to be, I'm not trying to criticize, but it's a respectful observation that many of those community supports, especially higher need Medi-Cal members in those waivers, we have significant concerns about, and you've heard this before from us, plan readiness. And so far from the numbers we can see, many of these services just aren't available in most of the states. So appreciate the opportunity to comment, and I will pass it to, who am I passing it to next?
Michelle. I think Michelle's going to go to Nina.
Hi guys, thank you, and thank you Nina and the other panelists. My name is Michelle Rousey, and I'm a dual, which means I'm on Medi-Cal and Medicare, and I am under managed care. Limited provider availability and consumer choice. From a personal experience as a dual eligible, trying to get a primary care provider who is competent to address my complex medical needs has been almost impossible, and most of the time over the last 6 months, impossible. When we throw people into managed care, both HCBS and medical care, they have to utilize the MPC list, which means the primary care providers list from the managed care plans to address those needs and to be able to get a doctor. Being pushed into managed care has not met my needs, even straightforward standard medical ones. There's a full range of services I cannot access. For example, I haven't been able to access dental services, mammograms easy for years because of mobility issues and complex needs. It is really difficult to find a provider to address services, let alone have the limitation of being in my managed care plan. HCBS are even more specialized, moving MPCs and will impact consumer choice in HBCS even more. And HBCS is not even within that area of expertise and existing provider networks. If plans can't handle current duals and Medi-Cal services, then what will happen to very vulnerable individuals into these plans? We all should be asking that question. What will we do for contingency plan to prevent harm? Navigation. I've been active advocate for years and have been advocating for myself to get access for cures and since I was a child. Managed care plans make me jump through more hoops to get the care I need. I feel I'm fighting the system to get the care. Sorry, guys. The care I need, and whether it's with referrals or filling this requirement to get the services, not only my doctor has to do it, but me too. The extra red tape is just not right, and it's continual. I mean, and that's what I'm wondering is, not only the plans are going to have to do more red tape, but the providers are too. And where does that fit in as consumers? I'm already helping with my referrals and making sure that my doctors get the needed paperwork to my DME company so that I get repairs on my wheelchairs and other things done. This is impossible for some people to do on their own, and navigating it is becoming hazardous to my health. Sorry, guys. Not everybody can do this kind of advocacy. And for example, I asked for case management well over a couple years ago now. They told me that it would be in the next year, my managed care health plan. Now it's another year. And I fear that they may not be able to do it for more than next year. And it keeps getting pushed off as something my managed care plan can do because I'm a dual. I don't see how moving HBCS to managed care will help make things easier when I already have more issues in managed care. I can't get case management. I can't get basic medical services through them. Moving into managed care has added more barriers, made it more difficult to get services. When you need services, you want to be able to reach to a program or service and have it to be navigated. And if you ask for help, have somebody to help you navigate that system. That's not what we have right now in many times. And there are gaps into getting that navigation. And I know I'm not the only one that's filling that gap. Thank you, guys.
Thank you, Michelle. And you should check the chat because you're getting some love there. Joanna.
Hi, thank you so much. And I just want to say I'm honored and humbled to be invited into this space. So thank you for the time and opportunity to speak. I'm Joanna Glum, and I've been a full-time caregiver for the grandparents who raised me and a care coordinator for the mother who didn't. I've traded my career building years and wage earning potential to undertake for over a decade unpaid family caregiving. And I'll offer that for all the hours spent cleaning the corners of a hemorrhoid, I've spent double navigating the labyrinth of forms and waivers and insurers. And my experience gives me pause about this proposal to further burden managed care when California's informal caregivers bear already the burden of making these programs work in spite of themselves. Like many Americans, my mother, a dual eligible full scope recipient with disability, hasn't seen a primary care physician in years, aggravated by periods of housing insecurity. In Sacramento County, we have geographic managed care. And so from Molina, she was transferred without notice to Aetna, and when Aetna was discontinued, to Anthem. To be clear, she did not understand why or how these decisions were being made, only that she didn't know her doctor. And so I had to learn hiring respite for my grandmother while I moved my mother out of homelessness, searching for a case manager, and then staying on the phone for days in an attempt to learn not just years of back history, but legalese. My mother has had no continuity of care as she ages because of managed care's pre-existing limitations. I could only do so much, my time given in full to my grandmother's daily needs, but that I could and would step in to secure her housing and health needs makes my mother an exception, not a rule, to those who seriously risk falling through the gaps. My mother, who's an IHSS recipient, filling out a timesheet is already a challenge given tenuous access to email, to phones, to wellness. And this barrier is often only overcome with intervention of another. And when her Medi-Cal lapse because of simple paperwork, it's me on the phone. And as she grows older and her health needs, including cancer treatment, grow more complex, attempts to apply for HCBA waivers lead me only to wait lists. So while not included in the integration, when DHCS suggests coordination with managed care for IHSS and integration with waiver programs already unnavigable, I maintain concerns about the barriers to access currently facing eligible enrollees who rely on their caregivers to file for eligibility for care. More, our county's managed care delivery, our 1915C waivers, aren't available for share of cost recipients. And where will they, who are already in need of HCBS, go? I've been unpaid for so long because a Medi-Cal share of cost would have risked my grandmother's home, which she refinanced to take care of me. And as my 73-year-old father prepares for emergency neck and back surgery, I, again, am crunching the numbers, him unable to afford private care, but not full scope Medi-Cal eligible, trying to afford to age with dignity in place as part of the overlooked middle. I cannot afford more years of my life plugging these gaps, and I'm alarmed given that those who are already doing calculus of pay for housing or get the health care, paying hefty shares of cost to qualify for what Medi-Cal does have, are held back from what HCBS could be. I'm on Medi-Cal wholly due to my caregiving commitments, so much of which are spent navigating these systems, and the logistical burdens of the managed care program, in addition to care responsibilities, have led to delayed attention to my own medical needs. And I'm not the only one. When you propose another logistical crucible to learn and navigate, caregivers see more responsibilities, less time to access their own care, and so you'll find more of us in these systems of managed care. Our health outcomes deteriorating as a result of years of this work, further burdening these systems. And I want to be clear that this language of waivers and share of cost was language I had to search for. No one offered it. I want to be clear that I have the privilege of Wi-Fi, of English as my primary language, as well as an extraordinary scholarship-provided higher education. I feel underprepared and undersupported every day to understand what's going on. So imagine what it is not to have the privilege, to learn in this space, to be English legalese fluent, to have time, to even know to call yourself a caregiver and understand your rights and options therein. Because most California caregivers only call themselves sibling, or parent, or partner, or friend, or neighbor. Most are not met with social workers or case managers, except, as in my case, at moments of crisis on yet another hospital admission. And only then was I offered information about a local CRC whose resources are underutilized in large part because of this communication breakdown between managed care and everyone else. California's family caregivers are the last line of defense. We fill in the gaps in the gaps. We and our care recipients should not have to be literate in 1915C, in GMC, and every other acronym and policy and form required to simply receive support in living and aging in dignity in our chosen communities. And as we stare down the barrel of work requirements, of a potential but entirely likely loss of coverage for millions currently enrolled in Medicaid expansion programs, such as caregivers like me, it does leave me wondering that if the goal is to improve gaps in care, what do you intend to do with the existing gaps and the people who never asked to be responsible for filing the paperwork and filling them in? Thank you.
Thank you so much, Joanna, and thank you to our panel. I'm actually going to open it up now to the rest of the HCBS subcommittee for a few minutes of questions and comments, and then we'll move on to the DACLAC committee. Let me just monitor. Yes, if you have any, oh, Debbie, go ahead.
No, shocker. Debbie raised her hand. What? Hi, everybody. Still Debbie Toth with Choice and Aging, still silver hair and pink lipstick. The more coffee I have, the less pink it is. But so I thank you, all of you. Joanna, I don't know where you came from, but this space needs you desperately. Thank you for being here and thank you for sharing. I want to share, and it's Michelle's story, but messaging back and forth with her through this last year of her having her medications taken from her, having her be unable to access services, like somebody who is so resilient and spunky and full of life, to be in the space that she's been in is really, really, really hard as somebody who loves her, is a colleague with her, and it's not right. And I can't help but keep thinking over and over, these educated, intelligent, wonderful humans can't navigate the system. If they can't navigate the system, what is the story for everyone else? And I want to say that I think Joseph and his team put together a really fantastic group of humans that are gathering and going through this HCBS, integration work group. I think there are some of the brightest people. I mean, Hagar is probably one of the smartest humans I know. I mean, there are some really incredible people on this integration work group that are having these meetings, having these conversations. I am delighted that they're not happening in some vacuum somewhere else without the voice of providers and people with lived experience. Because like Cindy Soto's on that group too. We have caregivers on that group. Like and there are health plans, I'm looking at the comments, that are participating in that group, but none of that gets to the crux of the issue, which is we have not seen that managed care can successfully manage CBAS, let alone CalAIM and community supports, let alone adding more to the plate. And I think we all have extreme concerns about this. And yet I think we all share the same goal, which is to have people be able to have the care wrapped around them that allows them to live in their setting of choice with the support they need. So it is, I think, incumbent upon us to really look at, if we're not getting it right yet, can we pilot or can we pause? And I don't know, Joseph, I don't know what your marching orders are from the administration. You live in a different reality than I do because you have different things coming at you. All we can do in this space is say it's not working right now. We will continue to work with you. We will continue to have the conversations. We will continue to identify the needs. But until we get it right, we shouldn't be making huge sea change until we know that we're in a prepared space. I don't think this is a rejection of managed care. This is a rejection of doing something before preparation, before readiness, and before we have a clear system to pilot, pause, check, evaluate, assess, and then change, and then try again. Like, we need to be able to do this intelligently, carefully, cautiously, empathetically, all of those things, so that people don't continue to get hurt. Thank you.
I'm going to move us to really quick, just in case there's anybody on the DACLAC whole committee that has comments, and then we're going to move to transportation because apparently we are running late. So if anybody has comments from the general committee, Kathleen?
Thank you. I just want to say, Joanna, you go, because, my observation over many decades of working in the community and also working, and some partnerships with healthcare and talking to a lot of healthcare organizations over the past year, when we talk about silos, one of the big misses that I see is that whoever is assigned, whether they they do contracts with other entities to perform these services, or they bring it in-house, or whatever the story is going to be, they're not connected to the community. I've never seen ever anybody from a healthcare organization in any of the coordinating meetings that we all have at local levels, which is where we all know, what's going on in the community and, where the needs are. We don't see a level of participation that gets these tentative programs out of the hospital or plan system and out in the communities, which is where they should really be located. So, I just need to mention that because you can say you can say the right terminology, but still not have a local connection to the community that we're working in. And that's actually pretty devastating. So just wanted to make mention of that. And we're pushing this pretty hard with a lot of these very fragile populations that we see in the caregiver resource centers. So that's it.
Thank you, Kathleen. Does anybody else from the DACLAC committee have a comment or question? I know there are a lot of questions also in the chat. If DHCS folks can skim that and see if there's anything that you can answer in there, that'll be great. Barb? Barb, are you there?
Yeah,
Did you raise-
no, I am sorry. I had to unmute. I have had several conversations with health plans that will remain unnamed that have also expressed that they're concerned that they've been given by upper echelon that this is what they have to do, but they're not ready. And they're trying to set up meetings with us so that we can talk about what we know about whether it's AIDS waiver or whether it's HCBA or assisted living waiver. And I want to go back to, 15 years ago when we started doing all these managed care components and lessons learned. And I think Debbie's idea of a pilot and testing it and figuring out one of the, what works and what doesn't work is so valuable. Because otherwise, what we're going to have unintended consequences to the human beings that are sitting around this table. And Michelle and Joanna are two examples of what we've heard about today. And so I really wanted to say, Joseph, and I know that you have people that you have to report to, but I think the concept of a pilot and slow down, because I think if people are really honest and people are afraid, they're afraid to make these comments because they're afraid they're going to lose their contract and they're afraid that they're not going to get funded and all of these other fears that are there that are real. But it comes down to it, we're dealing with human beings and we're not making widgets. And so the idea of looking at, a pilot makes a lot of sense to me. And I've written some comments in the chat about just basic things like we're going down this pathway. We're still making multiple changes that are massive to our documentation system that all the waiver agencies are using. And now we're integrating some of that for CCT. And it's like, if we're spending millions of dollars on these upgrades, which I know it's costing because I know what I have to pay for my upgrades, why are we doing this when I've asked the question, are we going to then turn this over to the health plans and ask them to maintain the same systems? And the answer is no. It's like, I don't get it. And it just doesn't make any logical sense to me. We've been flat funded since 2018 as providers, and this is across our entire system. So one of my concerns is now we have a middleman, the health plans in this versus directly contracting with the state. What's going to happen? Are we going to be cut back? Are we going to be flat funded? Are we going to have an increase? And I'll tell you now, working with the health plans on all of the managed care things with ECM, enhanced care management, community supports, each of them have their own unique way of documenting, and they're constantly changing every month. So we're having to spend lots of time and energy on reporting that doesn't go back into patient care. So I'll stop with that. I love the concept. I don't know if you could bring that back to whoever you report to Joseph, about doing a pilot, because I really think this is where we need to take a pause and do a pilot. Thank you.
Thank you, Barb. I'm going to actually let you, Joseph, have the last word before we move to transportation, in case you wanted to say anything, and then we're going to move on to our next subcommittee.
Thank you, Agar. And thank you to all the members of the reactor panel. Really appreciate you taking the time to to share your experiences with us, are just your thoughtful, analysis of the gap analysis and the work that we're trying to do and raising these questions and issues, because they are very important. Um, um, and I think that there was a lot. It could take a while to address everything, so I'm not going to be able to address everything. I know there's other things for you guys that you have to talk about today, but I just want to emphasize that we've been, like, you bring up a lot of good points. These are important things. It's important that in doing this that we get it right. And as part of that, we've been really intentional in saying this is going to happen no sooner than 2028. Not this is going to happen Jan 1, 2028, but this is going to happen no sooner than 2028, because there's a lot of work that we have to do to make sure that we get this right, that we're building on experience and lessons learned from things that you raised, like implementation of ECM, of community supports. What have been challenges there? What are we, having to address there? Also, recognizing issues seen in the long-term care integration. Questions raised around, that continuity of care process, having, plans having to actually, not just make contacts, but enter into contracts and agreements with providers, ensuring payments are made, that payments are timely. Also, recognizing, and these are things that we've talked about in the work we're going to continue to talk about, that this doesn't represent added burden for the member. It's meant to reduce burden. We're not talking about completely replacing how people currently get their services, the providers that they work with, how their care is managed. But how do we maintain that close, comprehensive care management that's provided through the existing care case management agencies, and home or community-based organizations, and have that, because HCBS is meant to be on the ground, like in people's homes, care and case management, not products. So I just want to recognize those pieces, and that it's super important that we take the time necessary to make sure we're getting this right, that we're planning this out, that we're taking these questions into account. And there's a lot of work still that needs to be done there. So, but I really appreciate all the feedback that we received today.
Thank you, Joseph. And we are going to now move to our transportation subcommittee led by Michelle Rousey and Warren Cushman. And I think Adina, you're going also to be presenting. And then that will be followed by a period of public comment. So please stay on for an opportunity to make public comment after this presentation. Take it away, Michelle.
Hagar, did Warren drop off?
Oh, I don't know.
It's okay if he has.
Yeah,
I'm here. I'm still here. I'm still here.
Somebody muted me. Okay, am I unmuted now? Okay, we're good.
You are, Michelle.
Warren, could you please raise your hand? There you go.
Okay. Thank you, everybody. This is the DACLAC Transportation Subcommittee priorities discussion. And before we do that, I'd like to welcome Warren Cushman as my co-chair for this coming year and going forward. And he has a long history of transportation and disability advocacy. And I just want to welcome in his new role as co-chair of the transportation sub for the DACLAC. And so we're going to go into some of our priorities discussion. The State Transit Transformation Task Force Accessibility. The State Transit Transformation Task Force was created by the 2023 budget, providing funding for public transportation, SB 125. The task force to make recommendations to the legislature and administration to fund and improve transit. due in 2025. Members of business, labor, academics, advocacy groups, and agencies, initially unclear if it would cover accessible transportation. Thanks to vocal support and advocacy, there are good recommendations. Laurel Paget, Seekins, and public advocates on task force, David Azevedo of ARP, Technical Advisory Board, and many community comments were given. Next slide, please. What are recommendations and what next steps to make change happen?
Michelle, do you want me to jump in and really abbreviate the next elements here? Yeah. So the focus of the DACLAC transportation had a couple of overlapping issues, and one was to follow and encourage a couple of state processes around funding for accessible transportation. And the second was to follow along and make recommendations about that state transit transformation task force as it related to accessible transportation. So funding was an extremely high priority element because it is really not possible to make improvements to accessible transportation if the costs to deliver those improvements are entirely unknown, as they have been. Next slide. All right, this is, let's see, next slide. Okay, sorry, I guess rewind. The slides were very much abbreviated, so I will keep them as they are. So there were two processes in the last year looking at a funding needs assessment for the entire of the funding system for the state of California and for the transit system. And while these processes did not succeed in coming up with a cost estimate, they did conclude, both of them, with a recommendation that it was essential to do and with follow-up next steps to complete that cost assessment. And the attention of the DACLAC transportation and other advocates was important to get that on the radar screen and to get that as a recommendation. Next steps. There were several other recommendations relating to funding, including medical transportation cost sharing and the ability for local and regional bodies to be able to determine priorities for federal Section 5310 funds. On the first item, legislation is going to be needed, and there's an important question as to when. And on the Section 5310 funds, there may be an administrative direction before turning to legislation. In the interest of time, you can move on to the next slide. There were also many good recommendations for making accessible transportation and paratransit more coordinated and user-friendly, including some recommendations for the state to be able to provide supportive guidelines and tools and technical assistance for operators around the state. A number of these changes will be able to be addressed administratively, and it's going to be important for organizations and people with lived experience to follow along and encourage these recommendations to be implemented. Next slide. With regard to accessible stops and stations, there were recommendations to advance ADA transition plans, which have been stuck in many places since the 90s, and a powerful policy opportunity to link ADA transition plans to funding. Next slide. And the DACLAC Transportation Subcommittee has gotten partway through discussing the robust set of recommendations for accessible transportation from the SB 125 task force. And that conversation will continue at the next meeting next week, Tuesday at 4 p.m. by Zoom. And folks who are interested in understanding the recommendations and weighing in on the next steps to implement them are very welcome to join the conversation under the leadership of Michelle Rousey and Warren Cushman facilitating.
Thank you, Adina. Yeah, I really encourage members of the DACLAC and the public to attend our monthly transportation subcommittee. And if you need more information on how to join us, let me know, and or Adina know, and we can get you the links to join us on our monthly call. And we would appreciate any push from members to get other advocates who want to work with us on transportation issues to join the subcommittee. Thank you, everybody. Any questions, comments this time?
Go ahead, Debbie.
That just rolls right out of your face like you say it all the time. So hi, everybody. Debbie Toth again with Choice in Aging. I know that I'm a broken record, so apologizing in advance to everybody. But this really, when we look at all the advancements that we've made in the state of California relating to aging and disability services, this is the one area that has been left in the dust. We have not seen, I mean, with Adina's help and support and policy prowess, we have been able to navigate in new spaces, but we're not seeing outcomes from that. We are not seeing outcomes from that. We are not seeing that people with disabilities and older adults can get where they need to go when they need to get there. Period. End of statement. Full stop. We have seen all kinds of road widening. We have seen all kinds of HOV lanes. We have seen fourth bores in the Caldecott Tunnel. I could list all of the transformation we've seen for bikes, for commuters, for everybody except for older adults and people with disabilities who cannot drive themselves around. And when Michelle is inviting you to come, she's inviting you because we need to have, and Adina too, a groundswell of advocates showing up and demanding that we do better, that we calculate out based on what 1 in 4 Californians has a disability and 1 in 5 is going to be an older adult by 2030. And yet it is not an area we even know what it costs to provide services. And I put in the chat, could you imagine Department of Healthcare Services having zero clue how much it was going to cost them to provide long-term supports and services? Like they're calculating a budget every year. The Caltrans, the CalSTAs, our state has 3 different agencies that manage transportation, and not a single one of them has a budget or an idea of what it costs to get people where they need to go when they need to get there. So to me, we can create every accessible space in the world, but if people can't get to it, what is the damn point? And the Americans with Disabilities Act, folks, is the floor, not the ceiling for what should be. That's it.
Thank you, Debbie. And that goes to the point, you know, if the floor of transit services for under ADA is so minimal now, why aren't we looking to go above that and make services accessible to what they need to be for people to be able to get to where they need to go when they want to and need to? And thank you, Debbie. Your points are so needed, and we really appreciate your advocacy with transportation. And everybody who's been supportive of the subcommittee, I want to appreciate your support in going forward. And like I said, please join us. We need your advocacy, even if you're not sure about how you can give input. If you use our public infrastructure, which all of us do for transit, whether it's you're driving, bicycles, you know, we're all using that infrastructure. And so we need to remember that we all age into disability, and transportation is utilized in that aging and disability and aging concept. So, and they should be there and they aren't. And knowing how much that funding is, it should be a no-brainer. But we've had to fight for I don't know how many years just to be at the table, let alone get anything done. So thank you, Debbie.
Thank you, Michelle, and to the Transportation Subcommittee. And we're actually going to slide right into public comments. So passing it on to Carol. Thank you.
Hi there. Thanks for staying with us. It's been an amazing conversation.
PDF and then save it as a secure the password.
Okay, we've got a couple people who are not on mute. If I can have the team go ahead and find those, that'd be great. I'm going to move to public comment. So I see Connie, you have your hand up. Please go ahead.
Thank you. Connie Arnold, disability rights advocate, 35 plus years. First, I'm going to tackle why I'm opposed to the proposal for Medi-Cal HCBS waiver recipients and participants carve-in into managed care. Medi-Cal model of care. The proposal follows a Medi-Cal model of care for service delivery, which does not align with the needs or rights of individuals who are entitled to receive services in their own homes instead of institutional settings. Challenges and grievances, as already expressed. Recipients may face significant difficulties in filing grievances against managed care systems for service denials or issues with provider payments. 3, increased estate recovery. The proposal could lead to increased Medi-Cal estate recovery, allowing the state to recover what managed care billed instead of what Medi-Cal actually paid. This disproportionately affects low-income individuals with disabilities and seniors over age 55, creating inequities for those who cannot afford legal representation. Number 4, Section 504 violations. The proposal may result in violations of Section 504, which requires non-discrimination in access to program services and activities. Number 5, complex care needs. Recipients with complex care needs may struggle to file ongoing grievances and appeals without a strong support network, especially against service denials generated by artificial intelligence, AI. Next one, risk of forced institutionalization. The proposal risks forcing HCBS recipients into institutional care, worsening their disabilities, or leading to death due to lack of access to necessary services, which is the true reason that for supporting managed care. Failed oversight. There is existing evidence of ongoing failed oversight in managed care plans and service delivery. Olmstead decision violations. The proposal may lead to violations of Olmstead decision, making it more difficult to litigate and resolve complaints from Medi-Cal beneficiaries. Lack of disability rights awareness. Managed care systems often are unfamiliar with disability rights, independent living movement, and the principles of the Olmstead decision. They follow a medical model that views us as patients needing treatment, just like the HCBA waiver does now, rather than individuals entitled to person-centered care and self-direction for services. The approach.
Connie, I'm sorry to interrupt, but can you please wrap up so we have an additional person who'd like to give a public comment?
Yes, I can, but I would like to say what I need to say here. People, as a disability rights advocate, it's basically turning our healthcare, our rights, into a long-term loan for our services through the HCBS waivers, and managed care charges exceed what Medi-Cal would actually pay. This is a problem, and as a disability rights advocate, I'm willing to set up a protest, chain myself to the governor's door again, and go through all of that because I'm opposed to managed care. I don't see it as an option. I see it as moving away from personal care services and the social model of care, and it's devoid of the fact that some people need managed care and some people don't need managed care. What I mean is they need managed assistance, not necessarily managed care, and that includes in the IHSS population. And I want to know how long my mother, who's in her 80s, is going to work for me, because these caregivers are not reliable and they are not dependable and they don't care. And really, it comes down to the fact that we need to pay providers more money and we need to move away from institutional care models and move towards supporting people with what their need is in the home, similar
Okay.
to what the DD system uses, but still, this is away from disability rights. And I would ask Mr. Billingsley to go back to his main boss, Michelle Bass, and tell her to do a redirection because this is the wrong direction that's going to kill people. Thank you.
Thank you, Connie. Let's move on to Christina. Go ahead, Christina.
Hi, can you hear me?
We can. Go ahead. Thank you
Cool.
very much.
Yeah, hi, this is Christina Lechman. I'm in San Leandro, California, and I'm a recipient of Medi-Cal, and I am a part of Hand in Hand and just generally disability advocate. And I am horrified hearing about what the plans are because it seems like the thing that I've heard a lot that like politicians tend to be like, oh yeah, we're for people with disabilities because they want to get votes. And like they're doing these awful things that absolutely are not for people with disabilities. So yeah, I want to express it's really scary that they would be thought that this is an option that may work because I switched out of managed care because it's great for people without disabilities, without special needs. So, yeah, I do not think this is a good option at all. So, yeah, I just wanted to express that. And I'm really glad that there are so many disability advocates and voices that recognize that and who are speaking up, because I just wanted to say that yes, please stop the medical restrictions, stop the cuts, because something that I want to say that I've heard that really rings true for me is that all I'm trying to do is boldly go where everyone else is already going. That's all. And every kind of restriction is against that. So that's it. Thank you.
Thank you, Christina. We appreciate your comment. I do want to direct you all. We are at 1 o'clock. We're going to have our director close us out on this very robust conversation today. And I do want to recognize, I want to ensure that everyone has the ability. Can we go back to the public comment and have our engage email address? engage@aging.ca.gov. Please feel free to send any of your written comments there. 2 minutes goes by fast. So if we can go ahead and close the meeting out, and it will be.
You got it, Carol. Thank you. And Christina and Connie, thank you for your public comments. Thank you to everybody today who raised their hand and raised their voice. This was a very good meeting. We heard from so many people and so many perspectives. Joseph, thank you for joining us and representing the Department of Healthcare Services. And to Sherry and Hagar, thank you for helping us construct such a strong agenda for today. To all of you, thank you. and have a good afternoon.